Good evening. It is the time just to start with the session. My co-chairman is Professor Guianyu Wang from China. It is a pleasure to chair the session with you. It is so-called long oral session, so 10 minutes for one presentation together with the discussion. And the first it will be the presentation from Japan, Toru Kojima, clinical implication of lymph node dissection for intrahepatic cholangiocarcinoma, a multicenter analysis of 385 resected cases.
Thank you, Chairman. I'm Toru Kojima from Okayama Saisekai General Hospital in Japan. I'd like to talk about clinical implication of lymph node dissection for intrahepatic cholangiocarcinoma. To evaluate the clinical impact of lymph node dissection, multicenter analysis was performed. This study was conducted by Okayama Study Group of Hepatobiliary and Pancreatic Surgery. This study group includes 20 hospitals, and 16 of them were board-certified institutions of Japanese Society of Hepatobiliary and Pancreatic Surgery. 385 patients were included in this study. Median age was 69. The patients were divided into 3 groups: right predominant group, left predominant group, and higher group. The number of the patients of each group were shown here. In terms of macroscopic appearance, the number of the patients were shown here. Of the total of 385 patients, 271 patients, 70% of patients underwent major hepatectomy, and 114 patients underwent minor hepatectomy. Bile duct resection was performed in 115 patients, and 101 of them were HeLa type. Lymph node dissection was performed in 264 patients, which ratio was 69%. The aim of this study is to investigate therapeutic value of lymph node dissection in ICC. First of all, we investigated clinical features of lymph node metastasis. Secondly, we evaluated effectiveness of lymph node dissection. Thirdly, we analyzed impact of adjuvant chemotherapy and lymph node dissection. First of all, I'd like to focus on clinical features of lymph node metastasis. 264 patients underwent hepatectomy with lymph node dissection, and 107 patients, 40% of patients, had lymph node metastasis. This slide shows the relation between tumor location and lymph node metastasis. The ratio of lymph node positive patients in a predominant right lobe group was 30%. The ratio of in left dominant group was 40%, and HeLa type was 46%. Risk factors of lymph node metastasis were statistically analyzed with logistic regression analysis. There were 5 factors, as shown here, were independent risk factors: periductal infiltrating type, HeLa or left predominant type, zero-zero invasion, poorly or moderately differentiated type, and high CA99 level were independent risk factors. This is the Kaplan-Meier curve of overall survival based on the status of lymph node metastasis. The prognosis of lymph node metastasis positive patients, in this line, was significantly poorer than negative patients. The prognosis of the patients without lymph node dissection, this line, was similar to the patients who underwent lymph node dissection and had no positive lymph node. Secondly, I'd like to focus on the effectiveness of lymph node dissection. Before evaluating the effectiveness of lymph node dissection, I'd like to go over the definition and area of lymph node dissection of ICC. Dissection of number 12 lymph nodes, which is located within hepatoduodenal ligament, is defined as normal lymph node dissection. In the case of the lesion predominantly in right lobe, normal lymph node dissection with number 8A, 8B, and 13A was defined as extended lymph node dissection. In case of predominantly in left lobe, normal lymph node dissection with number 1, 3, 5, 7, 8A, 8B, and 9 was defined as extended lymph node dissection. In order to investigate the effectiveness of lymph node dissection, we compared two groups, hepatectomy with or without lymph node dissection. Tumor size was significantly larger in lymph node dissection group. The ratio of periductal infiltrating type, multiple type, and highlight type was significantly higher in lymph node dissection group. The serum level of CA99 in lymph node dissection group was also higher. These results may indicate the cases of lymph node dissection group included more advanced cases than the cases of no lymph node dissection group. This was survival curve of two groups with lymph node dissection group and without lymph node dissection group. There was no statistical significance between these two groups. However, we should keep in mind that the lymph node dissection group have many advanced cases. This figure shows overall survival of extended and normal lymph node dissection group. There was no statistical significance between these two groups. Next, I'd like to share this table. This is a list of overall survival case. This is a list of long-time survival cases in spite of having lymph node metastasis. All the cases underwent major hepatectomy with extended lymph node dissection. We think that the fact suggests lymph node dissection might contribute to the long-time survival in cases with advanced ICC. Thirdly, I'd like to focus on the impact of adjuvant chemotherapy. This figure shows survival curve with or without adjuvant chemotherapy. There was no significant difference between these two groups, but when we analyzed only lymph node positive patients, adjuvant chemotherapy significantly improved overall survival. This is my conclusion. Lymph node dissection in patients with ICC is variable for some selected cases, and identification of nodal status is very important and useful to predict the effect of adjuvant chemotherapy. To obtain the exact staging, lymph node dissection is needed. From this study, we think that lymph node dissection in patients with ICC have some benefit and should not be denied. That's all. Thank you for your attention.
Thank you very much. Just a question, please.
Alessandro Vitale from Padova, Italy. Which is the number of lymph nodes harvested in your experience? Because it's important, the number, and which is the proportion of patients with at least 6 nodes harvested, because it's important for intrahepatic cholangiocarcinoma.
Thank you for your question. Almost positive lymph nodes were located within hepatoduodenal ligament, number 12, and some lymph nodes located in 8A and 8B.
Which is the mean number? The mean number of lymph
mean number? Sorry, we don't analyze that point, but probably 3 or 4, I think.
I have a question to you. Do you recommend just the frozen biopsy from the lymph node during the lymphadenectomy, or just in every case you decide just to do lymphadenectomy?
Thank you for your question. We didn't always do a closed section, closed biopsy. And in this study, we analyze only permanent histology.
Okay, thank you. Thank you very much. We proceed with the next presentation.